Welcome back. Today we are looking at the crucial variables that directly affect the clinical management of bipolar disorder. We can break these down into three main categories, which are the current episode, the temporal course of the illness, and the presence of comorbidities. Let us start with the current episode. The specific type of episode, whether it is hypomanic, manic, mixed, or depressed, is the primary driver for your drug choice. Next, evaluate the overall severity, which will dictate the need for inpatient admission. Similarly, any suicidality or risk of harm not only decides admission but also flags a potential need for electroconvulsive therapy. If psychosis is present, this is a clear indication to initiate antipsychotics. You must also determine if the patient is currently on or off medications. This helps you decide whether to start a new mood stabilizer, optimize current doses, add medications, or critically review and potentially stop any antidepressant monotherapy. Do not forget to assess sleep and circadian issues, which may indicate the need for sleep medications or interpersonal and social rhythm therapy. Finally, the presence of metabolic syndrome will heavily influence which drugs you can safely prescribe to the patient. Moving on to the temporal course of the illness, demographic factors like age and gender are vital. Treating a child, an elderly patient, or a female of childbearing age will significantly alter your pharmacological choices. You must analyze the number and type of past episodes along with the patient's interepisodic functioning. Polarity plays a major role here. For a predominantly manic course, lithium is generally preferred, whereas lamotrigine is preferred for a predominantly depressive course. Pay close attention to the temporal pattern, specifically looking for a reducing gap between episodes or the presence of rapid cycling. If you observe rapid cycling, you need to stop any current antidepressants and thoroughly review their thyroid function. Always look at the patient's pharmacological history to see what has worked in the past, any side effects they have experienced, and any history of medication poop-outs where a drug simply lost its efficacy over time. The third major category involves concurrent comorbidities. Comorbid substance use often steers the pharmacological choice toward valproate. Thyroid dysfunction is common in this population and must be corrected if present. Other general medical comorbidities will further restrict or guide your choice of pharmacotherapy. Always take a thorough family history because a medication that successfully treated a first-degree relative may very well work for your patient due to shared genetics. Lastly, evaluate for any ongoing interpersonal issues, as these are a strong indication for incorporating interpersonal and social rhythm therapy into their comprehensive treatment plan. Keeping these three broad categories organized during your assessment will make your clinical decision-making much more precise.